everyone. I take this opportunity to welcome you all on behalf of Hetero Healthcare. And my name is Neeraj Prachar. I'm the sales manager for Healion, which is a CNS division for Hetero Healthcare. To start with, I thank you all for joining us today for this webinar, which would be very informative and which is based out on the subject of aging brain, its management with the use of Rivastigmine. Prior to start with the proceedings for the evening and this webinar, I would briefly take this time, to share about Hetero Healthcare. Hetero Healthcare is an organization which started as the largest R&D wings, who had been providing 360-degree solutions to the related industry. Also, Hetero Healthcare has more than 25 years of excellence in multiple therapies when we are talking about. And not only in terms of therapies, but also it is in India, but globally, we have been having a presence in around 21, 26 countries across the globe with more than 200 products across various therapeutic segments like cardiovascular, oncology, HIV, antiretroviral drugs, CNS, and so on. Hetero Healthcare also has a very important distinction of bringing 4 biosimilars into oncology, which has been now accepted and being used across the globe. Also, to speak about Hetero, we have around 36 state-of-the-art, manufacturing facilities in India and outside, which have been pioneers in terms of providing quality and innovation, once again, to the related pharmaceutical industries. So with this little brief, now I would like to take this opportunity to welcome, Dr. Suresh Bansal, an eminent neurologist from Chandigarh, who would be speaking and sharing about his wisdom in terms of, the shared topic, which is aging brain. Dr. Suresh Bansal did his MBBS in 1971 from Punjab University, and post which he did his MD in 1976, once again in General Medicine from PGI Chandigarh. In 1985, Dr. Bansal did his MD in Neurology in the year 1985. Post which, Dr. Suresh Bansal has been working as an associate professor in PGI till 1994. And in 1995, did set up his neuroclinic in Tri-City, which was one of the first private clinics in Chandigarh during those times. Dr. Suresh Bansal has been a distinguished neurologist with 7 decades of diverse experience and is a dedicated educator. Dr. Bansal has mentored medical students, pediatric and psychiatric postgraduate students during all his tenure. Also, Dr. Suresh Bansal has been recognized by World Health Organization and also by Indian Academy of Neurology for his contributions to the related field. Not only this, but Dr. Bansal has also authored 40 research papers and firmly believes in transforming power of words and actions. His books, which he has been writing, reflects a lifetime which has been devoted to healthcare, and they show an impactful communication. Echoing the objectives of personal growth, fulfillment, and self-realization, Dr. Bansal asserts that writing serves as a potent tool for communicating thoughts and desires and knowledge, showcasing its profound impact in terms of shaping the life of patients and people in public. So with this little brief about our eminent speaker for the day, Dr. Suresh Bansal, now I would request sir to kindly initiate the proceedings and take us through the subject for the day, which is managing how to manage aging brain in current scenario. So sir, I would now request you to kindly initiate and take us through. Thank you.
Okay. See,
Yes, sir.
Thank you very much for a nice introduction, nice words. I'm humbled, and good time to all of you, to the listener as well. My topic is on the aging brain. You see, aging is one of the important thing. The time concept and the aging, we cannot stop aging. It's a degenerative process. There is simultaneous regeneration and degeneration ever after our birth. Regeneration is more at the time of maybe up to till adolescence or middle age, but thereafter starts the degeneration more as compared to the regeneration, and we start getting into age. So most of the time, most of the things are in the past worked on the aging of the body. So my topic, my interest, and my deliberation is based on the aging brain. So in which way the brain gets aged, and in which way the person is going to have, or the family, anyone is going to have difficulties, and in which way the word is going. Because let's say, despite of having very good locomotory system or health, physical health, in case we are not having good this cognitive functions or memory or behavioral issues, let's say we are 80 years, but we are not vigilant about ourselves, about the surrounding social factors, knowledge or experience, then it creates problem. That's what I'm going to talk about. Let me have the first slide, please. Naveen, show me the first slide. Yeah, see, first of all, this is the most important thing is, no, first slide only, first slide only. No, first, before that, what I wanted to say, that we have to be vigilant. We have to be careful that there is going to be some sort of aging as far as the brain is concerned. The concept of treatment of aging continues to be on the same process. A stitch in time saves nine, or prevention is better than cure, or make the hay when sun shines. See, once we are recognizing or starting the treatment rather early and vigilantly, we are persistently keeping the things in the right perspective, we can increase the quality and quantity of life. Next slide, please. You see, I must say, presently WHO is having a lot of interest, and this decade of 2020 to 2030 is a decade of WHO which has been devoted to the aging persons, and they have put up the criteria. What is aging? You see, there may be different perspective, different narrative, and different concept as far as the ethnicity is concerned, various countries is concerned, developing or developed. But as far as the WHO is concerned, they have taken 10 criteria on the basis of which they are going to define aging. See, before I just go ahead, I must say that the aging is one of the important things. There may be a person who looks aged rather early. I will say the cutoff point of aging is concerned is the different from the different countries. As far as the India is concerned, it is 60 years, 65 years as far as the legal codes are concerned in India. But let's say in Japan, it is 82 years. Let's say in German, it is different. So different countries having different type of cutoff point as far as the aging is concerned. And as the process of aging is, who is aged, who is normally aged, that is based on the concept of these 10 parameters, which is based on social factors, mental factors, physical factors, and overlap, like independence, whether a person is independent or not, there is a social support or not, what is the attitude or the overlook, self-awareness, physical activity, faith, diet, and lifelong learning, financial security, etc. Because in the old age, financial security is one of the important thing which is cribbing most of us in the present family system world over. Next, please. See, next slide. I mean, hello. Yeah. See, the point is brain, mind, and human body motor control. See, this is very fascinating to me. Till you see, I am now 76 years and a neurologist with a almost and a doctor for 53 years experience. I was not very clear between the difference of neurologist and neuroscientist. Neuroscientist is going to talk, is not definitely going to be a doctor. There may be a person who may be engineer, there may be somebody else, but going to work as far as the biochemistry or the biology level or the molecular level of that of the brain. So that's important. Sometime all of us, we will say and we will agree to this, that there is energy only by virtue of the matter. There is a mind or the function only by virtue of the structure or the brain. And obviously, if there is a brain, there is a mind. I mean, there are various ifs and buts, but I will stick to all these things because of the time shortage. And then there is a human body. The human body is affected as far as the transportation is concerned, my language is concerned, going from one place to another place is concerned, doing activity. You see, this whole world is nothing but human skills. You can see all this. I'm talking to you on the laptop, the communications, the exodus in the digital communication. This is all by virtue of the human hands. Obviously, by the program data or the reprocessed data or the execution of the data which is taking place in the human brain. Next. Is this slide? Yeah. So the aging, what happens most of the time, the brain shrinks. No, shrinks, the brain is comprising of many things, like there is a gray matter, there is a white matter, there are blood vessels, there is some fluid also inside and outside the brain known as cerebrospinal fluid. So there is a problem as far as the aging is concerned. Brain shrinks. There is a decreased brain blood flow. There is a degenerative process as far as the brain cells, neurons are concerned. And there is a deficiency of the memory. That is what is known as dementia. Next. You see, this is just like a walnut. I will tell you what is neurology and psychiatry. Most of the people, most of the time, I'll say even well-informed, intelligent, and sitting on the helm of affairs, they do not really know what is the difference between neurology and psychiatry. See, the left side of this walnut, you can see the brain is neurology. The right side is psychiatry. Let me show you further. Go ahead, Naveen. See, now the left side is brain. This takes care of as far as our consciousness is concerned. Not going to detail as to the consciousness is concerned. Its exact definition, its exact cause, where does it lies, is still in the mind of so many billions or millions of persons who is working on this. As far as the orientation is concerned, again to the time, place, person lies on the left side only, and it's a cup of tea as far as the neurology is concerned. And this is affected because in dementia or in the aging brain, this ages not only the left side of the brain, this affects the right side of the brain also. I'll come to it shortly. There is a memory, there is a problem in the learning, especially the newer memory, the old memory. You see, the first word which most of the people will say ma, mom, and the last word which goes as far as the memory is concerned is mom. So it is basically the recent memory which is affected as far as the cognitive decline is concerned, and the intellect. The intellect also on the left side. From the intellect, there is intelligence, then there is a knowledge, then there is a wisdom. Not going to detail again. Show me the right side. Now, as far as the psychiatry is concerned, this is more linked with the thoughts, attitudes, logistics, innovations, positive thoughts or negative thoughts, behavior. So because of the abnormal behavior, most of such kind of patients, they present with abnormal behavior, and the attendants not fully aware of the aging brain, they take these sort of patients to the psychiatrist. Basically, this is because of the degeneration of the brain. There are other factors in case we are going to look in between the line, which is affecting the memory, orientation, intellect also. See, what I've written below the behavior is SQ. See, let me talk of the various things like IQ, intelligence quotient, PQ, performance quotient, VQ, verbal quotient. This is a neurology. And SQ is social quotient. This is psychiatry. And more than that is EQ, emotional quotient. So emotional maturation, emotional learning, emotional quotient nowadays is very important as neurology is concerned, as cognition is concerned, as intelligence is concerned. So putting all the things together, I will say emotional quotient plus intelligence quotient plus we cannot forget the hard work. This is what can cut the ice for anything for everyone. Next slide, please. No, this is slide to put the things more simple. I do not want to go into more fancy words or into more details as far as the listeners are concerned. Dementia is a brain disorder that slowly destroys memory, and thinking skills, and eventually the ability to carry out the simplest tasks, the activity of daily living. Slowly, and this is a slowly progressive disorder. There are different type of dementias. There are certain dementias which I come to it, but I cannot discuss at length, which are rather quick, fast, and can create the problem. For example, I will say subdural hematoma. That can be after trivial injury as far as the brain is concerned. That can be life-threatening situation in case the surgery is not done within stipulated time. So we can lose such type of patients. So again, I said it's not only slowly progressive. Sometimes this is acute also, maybe metabolic. I'll come to it. People with dementia experience change in behavior, and there are various risk factors. No, risk factors are, I've mentioned only few, but there are so many. The one is, of course, the age. In aging, definitely a person who is having problems, the memory is concerned. So we may say this is mental retardation. From the very beginning, there is no cognitive development. But if the child is having proper development and then there is a deficiency as far as the learned memory is concerned, we'll surely label it as dementia. And usually in children, we do not see dementia. Of course, there are certain dementia which can be seen at 40 years of age, at 50 years of age. Hypertension or the high blood pressure is one of the risk factors. So is the cholesterol level, the lipids, coronary artery disease, the pump, the heart, because it has to put the brain blood flow to the brain, anti-gravity. That's why the pump has to be good. The coronary artery has to be good. Of course, diabetes. Nowadays, you see all of us, most of us, in most of the countries, we are not doing good or reasonable physical activity, and we just stretch time at the cost of our sleep also. In that situation, the weight, obesity is increasing and increasing. And then this obesity or metabolic syndrome is going to have all these things which is going to share a common platform, like diabetes, high blood pressure, lipid abnormalities, sleep apnea syndrome, and which is again very, very important. And there are certain other risk factors like genetic predisposition, of course, as far as the addictions are concerned. Some abnormalities, again, genetically predisposed, Down syndrome also, and there may be some mild impairment, which is not exactly Alzheimer dementia, which is not exactly dementia, but they can have some problem. The problem can be vividly seen, whatsoever they are doing efficiently, nicely, vigilantly, there is going to be decline as far as their mental performance is concerned. Next slide, please. You see, there is a demographic shift. See, at present, we are having about 6 to 7% of the Indian population more than 65 years of age who is having dementia or who having aging brain. Aging brain doesn't mean always dementia. They can have problem with the other aging things like human motor system difficulties, or there may be repeated falls, there may be Parkinson disease, there may be mixture Parkinson disease dementia process, or there can be other factors, agility is concerned, or the reflexes are concerned, comprehension is concerned, or diversified attention concentration is concerned. So all these things is not the part of the Alzheimer disease, but this is definitely part of the aging brain. Now this slide I'm showing, you can see the two colors, developed countries and developing countries. The developing country is in the lower part, in the light gray things. You can see how many people, they are slowly and slowly by 2050, how many people will be having aging brain. So there is a demographic shift. Why this demographic shift? I'll show you just now. Go ahead, please. You can see there was a time, in case I'm going to recollect 40 years before, the infant mortality rates used to be very high. Now the infant mortality rate is small. In that way, there is more pouring in of that of the infants or the children. So population is on increase. The population is also on increase because of the longevity of life. So the longevity of life globally, it is increasing. So overall, there is more infants, more children which is coming in, and there are less old age people who are dying. So by the result, there is an increased age of elderly population. Good or bad, there are many things which is being done by the various government in the various countries. So is true as far as India is concerned. But still, there is a short as far as the demand supply is concerned. There is a mismatch. There has to be not only domiciliary care, there has to be NGOs, they have to come forward to care or to introduce this sort of philosophy, phenomenology as far as the aging is concerned. Next slide, please. Now, I'll show what happens in the aging. As for the diagnosis is concerned, we are progressing. I see you, this is a time of artificial intelligence, machine learning, pattern recognition, so many other things. Now, this is the slice of that of the MRI of 25-year no normal person. You can see as far as the outer crown is concerned, this is rich. This is where the gray matter lies. You can see the inner side, again, white matter. And again, this white matter is basically the communication between the various areas of the brain, which has been assigned different type of duties as far as the special senses is concerned, as far as the routine senses are concerned, as far as the perception is concerned. See, unless there is a perception, there cannot be perspective, there cannot be from intellect to intelligence. So this is what is a normal brain. Can I see the next? So there is a decreased neurons. Over here, I like to show you a small clip as far as how come the degeneration of the brain occurs. Can I have the first video, please? See, this I've taken it from the National Institute of Health, Maryland. See, this is what you're going to see. In which way there is a shrinkage at the effect of the brain cells at the molecular level. Sound, please. Sound.
Pull down the axon to the end of the neuron. The electrical charges release chemical messengers called neurotransmitters. The transmitters move across microscopic gaps or synapses between neurons. They bind to receptor sites on the dendrites of the next neuron. This cellular circuitry enables communication within the brain. Healthy neurotransmission is important for the brain to function well. Alzheimer's disease disrupts this intricate interplay by compromising the ability of neurons to communicate with one another. The disease over time destroys memory and thinking skills. Scientific research has revealed some of the brain changes that take place in Alzheimer's.
Yeah, same slide, please. You see, you can see as far as this small video is concerned, in which way the communication fibers are concerned, they shrink and they cut off the neurons. The neuron shrinks, and over and above there is a deposition of abnormal material inside the brain that's known as amyloid. So you can see what is happening as far as the MRI is concerned in an 80-year-old person. And this is the lower picture. So over here, you can see there is a shrinkage of both the outer crown as far as the neurons or the gray matters are concerned. And inside also, there is a ballooning of some ventricles or the area as far as the white matter is concerned, that is also shrinked. And this all results into various things like problem as far as the memory is concerned, recall is concerned, comprehension is concerned. These are the guys who may have mumbled type of conversation. They are finding a lot of difficulty in multitasking, and there is a ability to follow verbal instruction is decreased, increased reaction time. So you are talking to them nowadays, as far as the youngsters are concerned, because of the shortage of time and impulsivity and the type of mindset they are having, the lifestyles they are having, they don't have much time to devote to listen to them, because they are going to take a lot of time as far as the reaction is concerned to the command. And they do have anxiety because of other reasons. Next slide, please. You see, this is a slide from the Lancet, which is one of the very nice journal, medical journal, common old age diseases. So over here, I will say dementia or the aging brain is fairly common. This comes somewhere over here. But the most common is, of course, as far as the heart is concerned. And again, I will say the light gray and dark gray. And dark gray is the low income and the light gray is the high income countries. So over here also you can see what is happening as far as the various disorders concerned, mitosis, cancer, or maybe cardiovascular disease, muscle degeneration, mental disorders, infections, diabetes, and other things are far more common as far as the developing countries is concerned. And so is the scenario in our country. Can we go next slide, please? You see, what are the various challenges had? So I wanted to tell you what is this aging brain, what is there at the molecular level, and in which way we are going to face the challenge. In each family, we are going to take care of, especially in those countries where there is a strong family systems like India, like some other countries also. But and I'll say in that situation, as for the domiciliary care also, that is far, far more better as compared to the institutional care or community health services, or maybe certain NGOs or missionaries who are doing something good as far as the old guys is concerned. So the various problems which we face in the old age is the access to the healthcare. So this is more true as far as the Dalits are concerned, as far the less privileged people of India is concerned, who is living on the countryside. There is a lot of social isolation. Social isolation is very important. I'll just come to it. Financial security is another thing. Please, please don't give. This is my suggestion to all those who are getting into age or aged. Don't become emotional fool and try to surrender your money or your acquisition to your children just out of so-called love, but it's a mad love, because ultimately this is going to be in a hierarchy also to theirs own, to them only. But don't give it before you die, because otherwise you are going to be less scared. So financial security is very, very important. And there are some laws also in India. There is a, as far as the patriarchal right is concerned, not from the father to the son. Now there is a son to the father also. And there is a age-related discrimination. Can I have more on this slide? Yeah, population. Population at present, almost 6% of Indian population, they are in the senior citizens, they are old age. And you see what is happening. Gone are the days when we used to have a lot of respect for our elders. And you see, there is a domestic abuse. Out of all these senior citizens, 6% of them, they are having abuse in one or the other form. This may be physical abuse, this may be emotional, or this may be financial abuse, or they may be just made to attend various courts. So that's very bad. And as far as the sustainability is concerned, they are dependent, living because of their physical incapabilities, as well as their poor immunity, and they are more prone to various sort of immunological injuries, infections, metabolic abnormalities, and they have limited finances. And obviously, and in the old age also, as far as the emotional learning is concerned, that also is challenged. So as for the Dalits or the ruralites are concerned, they are uneducated, they are landless, marginalized, malnourished. They may be having food to eat only once, one food in a day rather than three. They face violence more, which is results into morbidity, mortality. See on the left side. This is a slide which I have taken from the WHO. Now the WHO says the loneliness, no loneliness of different type. I'll say loneliness as well. This is, I'm not talking of solitude, I'm not talking of forced loneliness, I'm not talking, but the loneliness per se, in especially, you see, I'm talking to you. Some of the, maybe one of you or two of you may be lonely. Despite of listening, they are not listening to me, they are just lost somewhere in. So the loneliness of different type. I'm talking of the loneliness of the old age, wherein 50% they are on the risk as far as developing the dementia or the memory loss is concerned. 25% of them, they are having early death. And 30% of them, they are going to have increased tendency of heart rate, which is not a small number. So you can say how the isolation is going to crib as far as our parents, forefathers are concerned, which otherwise should be credited for, because they're having a real good horizontal knowledge, wisdom. They may not be having vertical wisdom. Vertical wisdom is more invested with the younger brain or the younger minds. Next slide, please. See, making the diagnosis. So history is one of the very important. I will show you the next video of the patient. Show me the next video, Naveen. This is of the patient who came to me from Himachal Pradesh. This is the hill state of northern India, see, this is the patient. I'm talking to the patient. Now, this patient presented to me with not talking. You see, what we see the contact making. Can I make the contact with this patient? I was not able to make contact. I was asking, he was fumbling or he was not reacting. I was asking him as for the day, date, time, what he has eaten, or where he is. Is he oriented to the place, Chandigarh, where my this clinic is there? What he has taken in the breakfast, and what is his even in his body parts, which is the left side. He will show the right side. And once I see touch the left ear with the right hand, he was not able to do that. So these sort of things, these are very important, that should be checked well in time, and even the slight deterioration should call a bell. That is the time when we can help these patients to a better level with the help of medication available in our country. Can I have the next, the same slide, please?
So should I play it?
No, that's okay, fine. Let's go ahead. The next same slide. That's okay. Let's forego this because time is the
Okay.
constraint. Yeah. You see, history, that's what I said, is important. And lifestyle is again, as I said, we are most of the time couch potato. We are having unhealthy eating, fast foods, hardly any fiber. The best diet, what can be there, I'll tell you shortly. And we don't do exercise. We just take the things as far as our body, mind, and other things is concerned for granted, that we are going to have nice go 80 years, 90 years, and we don't walk, most of us. And there is a problem as far as the evaluation program is concerned. It's not the psychometric evaluation is concerned, analysis is concerned. Most of such patients can present, as I told you earlier, also with behavioral abnormalities. Many of them, they present with depression. And there may be certain person who come with the memory loss, confusion, or irritable mood, impulsivity, or there is increased anger, or their behavior is such a bad thing, which is highly socially unacceptable. I must tell you, one patient recently came to me from Australia, she was taking, she's 82 years old, and she was taking anti-dementia medicines in Australia for the 6 years. And they were told that this is Alzheimer's disease and this cannot be cured. The patient came to me, nothing to boast about, but just I'm telling you my submission, these things occur. She was having depression because her EEG was normal, MRI was normal. I gave her antidepressant and she did improve wonderfully. There was no need of giving medicines for the dementia. So this is what sometimes depression present to us with pseudo dementia. It's not real dementia, but it looks like dementia. So we have to be very careful. As far as the investigation is concerned, they are also contributing. Various investigation which is done in such like patient is EEG, EMG, brain imaging, MRI, structural MRI, and positron emission tomogram. You see on the right side, this is one of the interesting thing, which is a cutthroat usefulness as far as the dementia patient is concerned. Of course, a lot is said as far as the treatment is concerned, vaccination and whatnot, or maybe stem cells. I'll talk shortly about that, but let me talk about the diagnosis. You see, in the upper, there are three sets. Upper set normal, in between center is the Alzheimer, and lower is the frontotemporal. So normal, you can see the amyloid PET and compare the Alzheimer, you can see the yellow deposition. This is amyloid, which I showed to you in the previous slides. And the PET scan is also abnormal. You see the frontotemporal. Frontotemporal is the frontal part where the analysis, critical analysis, and the in charge of the emotional or the intellect lies over there as for the frontal part of the brain is concerned, because this is the part of the brain which is almost 50% of the human brain. And this is what, by the virtue of which we, the human being, are more intelligent as compared to the other living human beings. So this can be, rather than the global degeneration of the gray cells or the brain, there can be only frontal area. On the right side, you can see the MRI, which can tell us that there is some sort of degeneration as far as the gray matter is concerned in the front also, on the back also. But this is more clear that this is frontotemporal area. This is only in the frontal area, in the middle area, rather than in the back area in the amyloid PET scan. Because amyloid PET scan is very useful. Can I go to the next slide, please? So with the help of the, as for the amyloid deposition, next slide, please. As far as the amyloid deposition is concerned, before that, I must say that I talked to you as far as the dementia. There is Alzheimer dementia. There is a deposition of plaques, the amyloid plaques, and there is a neurofibril tangles. Neurofibril tangles. This is what the pathology I'm talking to you. This is what I'm talking to you. The biopsy picture of that of the brain, which I've demonstrated. How this comes? What is the underlying factor for this? Is there some sort of genetic predisposition? Why a patient at 82 is doing good, why another patient at 62 here, we really do not know. But there are other factors also which is considered come into play, as well as the vascular factor, less brain blood flow, which is usually as with the primary neuronal dementia, in idiopathic dementia, Alzheimer is the one. Alzheimer may be seen in its purity, only Alzheimer, or this can be associated with the decreased brain blood flow also. So there is a mixed picture of both primary neuronal dementia as well as multi-infarct dementia. No, Lewy body disease. This is what is a type of dementia which is seen in females more as compared to the males, usually having aggressive course and usually associated with movement abnormalities. So extrapyramidal syndrome or Parkinson disease-like picture, and usually the expected age after it is detected is about 2 years only. Vis-a-vis, as far as the Alzheimer is concerned, the quality of life is affected, but they can live for a good number of years, maybe 8-10 years. Or they may have aggressive course also. There may be other comorbidities that all depend upon that. Can I have the next slide, please? You see, geriatric health is a teamwork. Can we want to help? Should we help these persons? I was just seeing today one small clip on the LinkedIn. The old guy is saying, "Is there any usefulness of my living? Why should not I die?" I don't know. It should be that simple to declare as far as the self is concerned, or the family is concerned, or the society is concerned. I also know they have having their own contribution. Their experience, large experience, is going to be valued in so many things. And then in case the health, physical health along with the mental health is kept nicely, rehabilitation is very good. I have seen people running at the age of 100 years, 104 years, as far as Kyoto is concerned, where I attended the World Federation of Neurology meet and listened about the stem cell therapy in the Alzheimer dementia or primary neuronal dementia. All said and done, this is not up to the mark or up to the expectation. So what I want to say is that as far as the care is concerned, definitely the care which I'm going to talk at the different level, this is not only at the primary level or at the family level. This is a collective effort by the family physician, by the social scientist, by the dietitian. So maybe as far as the family is concerned, so I'm not going to go into detail of this, but all these persons, they put a lot of contribution individually. As a diet is concerned, I said it, high fiber diet, Mediterranean diet, a lot of fluids in case the kidney is okay and the liver is, heart is normal, then fluid intake is very good for them. And as far as the high fiber diet is concerned, less fat is concerned, keeping ideal weight is concerned, having 8 hours sleep, avoiding hurry, worry, and curry. Curry means obesity. And that's very important. The lifestyle is concerned. Can I next slide, please? So that's what I was talking about. You see, this is the same, almost the replica of the video one, which I showed it to you, where there is a problem as far as the brain cell is concerned and their connections are concerned. You see, working, I've written 2 books on the mind, empowering the mind, or self-help books. While going through all those things, I came and I am of the definite opinion the human brain is highly dynamic, and they keep on forming new connections. Right now also I'm talking to you, every one of you, whosoever is trying to have good attention, concentration, and interested in the subject matter and is comprehending the things, new connections in your brain is being formed. So I'll come to that. That's why I say always, and that's what there is a saying also, use the brain or lose the brain. But in this slide, I wanted to say that by virtue of knowing about the amyloid deposition with the help of the PET scan and structural MRI, we can say we can plot a graph. We can quantify the quantum of the abnormalities which is creeping in day to day, week to week, or month to month basis. And we can see the cutoff point also, that at this amount of deposition of the amyloid, there is going to be dementia. So for that, now there is a treatment available. There is a monoclonal antibodies. This is again a geneticotherapy which can be given, and which is more like a nip the evil in the bud. So this can check. This needs to be done in rather in the early course of the disease, and this is being practiced in the developed countries. Can I have the next slide, please? Now coming to the drugs, there are various drugs. As for the rivastigmine is concerned, I'm using rivastigmine for almost 25 years. I did attend some of the international congress on Alzheimer dementia. That was I'll remember maybe 2 decades before. This was in Istanbul. But I'm using this rivastigmine for the last 25 to 30 years. In fact, I gave it to my father for 3 years with usefulness. The first was the Novartis, and they came with the name of Exelon. It was very costly, but there are now many companies, and you see, as far as their this ultimately therapeutic level is concerned, at the site of action, at the brain, passing the blood-brain barrier is concerned, is very important. And as for the rivastigmine is concerned now, but first of all, I must say, as for the should we compare or not? Rivastigmine, donepezil, memantine, and the other neurogenic substances. At this juncture, I must add that there was a concept, used to be concept, that there is not going to be neuro regeneration. But now we have found that there are certain grandfather cells which is lying dormant inside the human brain. Once we are in need of that, they become active. They can be made active by various virtues. So what I want to say, a patient of dementia is going to present various type of clinical presentation, just like 2 or 3 drugs, as far as I just quoted you, as far as the blood pressure is concerned. Same is true as far as the dementia is concerned. There may be problem in the motor activity, there may be fall, there may be carrying out day-to-day activities, maybe putting trousers, maybe putting shirts, buttoning, unbuttoning, breaking chapatis, feeding oneself, or carrying from one room to the another room, behavioral abnormalities, memory deficits, are repeating the things, and there is a problem as far as the swelling reflex is concerned. There may be choking, there may be repetition, there may be some sort of hallucination. So there are so many things which can be part of the aging brain. So whether should I say the rivastigmine is better than donepezil, or donepezil is better than rivastigmine, I will say both are useful. And I, most of the time, earlier donepezil was not available in our country. It's since 20 years this is available. Before that, to begin with, as far as the dementia is concerned, rivastigmine was available, and I have seen very good effect, useful effect, mostly with 3 milligram daily dose, or maybe 4.5 milligram daily dose. As far as the donepezil is concerned, this is available now in combination maybe with the memantine, and this is given. This is having relatively more usefulness as far as the multi-infarct dementia is concerned, and surely even in the primary neural dementias. But to my best experience of about 5 decades, I will say I would like to go to the as far as the dementia is concerned, even in the early stage, I would like to start both rivastigmine as well as donepezil, as well as something Ayurvedic. I'll come to that, because ultimately I am a doctor. I may not be doctor, but I definitely want the quality and quantity of that of the patient should be very good, and that's what I am for. I'm not for a particular drug or a particular system. I would like to practice all the system where my patient is fine. Can I have the next, please? Carry home. You see, one should have the realistic target. Ultimately, we have to go. But should we go unattended? Should not we go? Everyone, all of us, we want that we should come to this world laughing, and we should leave this world laughing. But for that, we have to be up and about, vigilant, and take care. Have a realistic target. I said it, use it or lose it. Sudoku, crosswords, puzzles, so many games. See, I remember the old guys, as far as India is concerned, sitting in the park near to their house, and they are just giggling and having fun, playing cards. So those were days. There are different types. See, they were doing all those things. What I'm trying to say, as far as school is concerned, crossword puzzles, card games, chess, reading, etc. So one has to having ideal weight. Exercise is very important. At least 5,000 steps or 6,000 steps are welcome, and those who can do it, nothing like that. Comorbidities, very, very important. I'll come to that. In which way the comorbidities can just make the things from bad to worse in maybe half an hour, 1 hour in a day, 24 hours. So that needs to be taken care of. So check isolation, plan retirement, valiant time, and social interaction. Next slide, please. And community living is very important. Community living is nowadays in India also. There are more type of old age homes. There are corporate old age homes also. There are community living also. There are NGOs also. They are paid also. They are free also. A different type of. There are about 709 something like odd senior citizen homes in India. So fall is one of the very important thing. 30% of these guys, they have fall by different virtues. This is because of the aging brain, as well as there are other things also where the fall is going. I'm not going to check into detail. Communication. Now, we should be short, simple command as far as the old guys is concerned. We should reassure them. We should make to sit with us as far as the dining table is concerned. Devote time on them. Should be gentle touch. So gentle touch is going to be useful. Even if we're going, two person are going to talk with each other, maybe unknown or maybe known, or maybe very nicely known, maybe husband wife. So in case there is a soft touch on any part of the body, not doing any sort of mischief, but this is going to have its own emotional positivity. Healthy diet, I said it. Domiciliary care is very important. It has been proved that the domiciliary care is useful, more useful as compared to institutional care or maybe by the NGOs or the missionaries. Next slide, please. You see, this is what I said. What can be the trigger? A person is in the old age, having reasonable amount of cognitive functions, even behavior, emotions, or thinking process, family has accepted, and that person is keeping reasonable active life, going for the walk, having nice sleep, but suddenly there is a problem. What are the things which can create problem? Stress, family stress, financial stress. There can be some sort of surgical intervention, simple cataract. I'll say the patient after the simple cataract surgery, they come to me and they say that there is a problem as far as the higher mental function is concerned. Minor brain attack, of course, small stroke can tilt the balance. Low sodium, metabolic abnormalities, hypothyroid. I have seen a patient came to me on the bed with the thyroid crisis and with the thyroxine and steroids, that she did very well as far as the cognitive improvement is concerned. The various drugs can cause deterioration. Low blood pressure can again cause brain blood flow is jeopardized, and there is a problem. Infection. You see, the behavior of infection in the old is totally different as far as the youngster is concerned. They may not be fever. There may be simple thing. They are not, they have become drowsy. They are not talking. They have withdrawn as far as the heart mental function is concerned. We have to be vigilant as far as the infection is concerned. Simple TLC, DLC is good enough to do the screening. Injuries, minor injury, I said it. Trivial injuries can cause subdural hematoma. We should be vigilant, and that can also cause sometimes hip fracture. That again is serious thing. And there can be benign memory loss also, forgetting name. So it doesn't mean that these are the patients who are they are able to have Alzheimer's dementia, multi-infarct dementia, other type of dementias. There can be forgetfulness. So all those forgetfulness is not equal to dementia or Alzheimer's dementia. So misplacing items, of course, difficulties in complex problem solving, or vision difficulties, hearing deficits, and poor reaction time, they can be added factors as far as the dementia is concerned, because again, with the age, there can be cataract, there can be otosclerosis as far as the ear is concerned, and there can be reaction time, which can be poor. Can I have the next slide, please? And the next slide is, thank you very much. This is my phone number and this is my email. Of course, I'll open to the questions, suggestions, and adding to what I said. But at the same time, I'll be happy to answer you anytime. Thank you very much. Thanks, everyone.
All right, sir. Thank you so much, sir, for the very knowledgeable session which you have taken us through. Jayant, now I would request you if you can share with us the queries.
See, I was to talk about the Rivastigmine available by the companies in the form of patch. Now, the patch is good. See, I didn't, I'm using this patch for the last about 8-10 months. See, there are different modes of drug delivery system, orally, or maybe in the syrup, or maybe through the skin. So the basic, once we are putting the skin patch, it is useful because this will bypass the liver and the bloodstream. This will go directly to the blood, and only thing it has to cross the blood-brain barrier to reach to the site of action. So in that way, the patch, Rivastigmine patch or the Hetriva is good. It's a good opening as far as India is concerned. And I will say their price is also almost equivalent as far as the oral Rivastigmine is available, something like that. Maybe little more. Surely it's not the same, but little more. But its usefulness is also more. Most of the time, one patch is used on a hairless skin, and the same patch area of the skin can be used after 7 days. And I have used it with beneficial effect, useful effect. And I have not found any side effect. As far as the Rivastigmine is concerned, or this particular patch is concerned, mostly there are certain other drugs also available in the form of patch. There can be sometime some skin rash or some other things. As far as my patient is concerned, maybe as far as the Hetriva Patch is concerned, or something, some or 300 patient, not many, but I have found it's all okay and helpful, useful. And I usually use the 9 milligram patch, wherein usually the drugs delivery system is something like 4.5 milligram. So I foresee other things also, like monoclonal antibodies come to such type of patients and will be available to our country soon. So surely I talked to the senior neuroradiologist also to come out with the structural MRI with the PET scan, so that they are able to diagnose the amyloid deposition well in time, and we can foresee the oncoming of that of the Alzheimer dementia or the other aging brain problem, and take the measures, therapeutic measures well in time. Yeah.
Right, sir. Sir, another query which has just come, is shifting from donepezil to Hetriva, which is Rivastigmine, sir. How do you suggest for the transformation, sir, from donepezil to Rivastigmine?
You see, in this, there are some number of crossing thoughts as far as my experience is concerned. You see, even if we are going to talk of this disease, dementia, aging brain is concerned, we are going to talk of epilepsy and certain other things. In the type of, in the way the pharmacy is being practiced in America or in certain other developed countries vis-a-vis in India, they are different. So over there, this is a specific type of drug. There may be combination which is not promoted. So as far as my own experience is concerned, at one time I wanted to give, you have asked a nice question, one medicine only. Should I give only Rivastigmine vis-a-vis? Should I give only donepezil, maybe alone, or maybe with other things like galantamine or memantine? The point of contention is, even there are certain other drugs, this available one dose system, wherein 23 milligram of donepezil long acting is also available. So should I give only Rivastigmine or donepezil? My own experience is, you may say me that, but I am for combination. See, I must tell you, as far as now the this I think Abbott, they have removed by virtue of the government instruction as far as the combination of phenytoin and phenobarbital is concerned.
Yeah,
But
sir, yes.
I still remember the father of epilepsy, India, Professor K.S. Mani in Bangalore. He
Yeah.
used to start his oration that this is the major anti-epileptic drug, cheap, effective. And I must say, without any criticism, without any bias, that those patients who are coming from tertiary care, national care hospital of national importance in our country, having 6 or 7 anti-epileptic drug, has been controlled very nicely with the combination of these two. Saying that, I will say, I'm not that Rivastigmine. I like to shift to donepezil. So most of the time I don't shift. As far as I'm concerned, I add. See,
Okay.
I want a result. In case someone is not able to, maybe some gastrointestinal upset, rarely seen with the rivastigmine, I may be going only for the donepezil with or without memantine. As I told you, I am for mixopathy. I do give Ayurvedic medicine also, which is Brahmi and Sankhpushpi.
Okay.
Is definitely good as far as the learning is concerned, dementia is concerned. So I don't mind putting this. You can say cocktail, you can say mixopathy. I don't mind getting labeled like anything, but my patient should be good. Believe me, my patients are good. Believe me, all those patients who will come in the advanced stages of the Alzheimer, I'm saying Alzheimer, not aging brain, Alzheimer disease from advanced institutes with a label, nothing can be done. They come to me. Even if there is a 20% improvement, 30% improvement, they are simply able to do activity of daily living themselves independently. That's good enough for me. And that's what I want.
Correct, sir. Correct. Correct. But still, sir, because this is a lot of time, sir, because I've been meeting, the other doctors, the young doctors, the upcoming doctors. Still that query comes, sir. Like if the patient is maintained for a couple of months, on donepezil, because speaking about rivastigmine, sir, as it works on both acetylcholine and butyrylcholine, right? So still, sir, what would you suggest? Could it be immediately be the patient would be transferred to rivastigmine patches, or sir, there has to be a some gradual transformation, where it has to donepezil overlaps with the rivastigmine.
No, I don't think, because first of all, we have to be more clear as far as the diagnosis is concerned. I didn't go visually into detail. We should go for the psychometric evaluation. We should go for the structural MRI PET scan, and we should evaluate the molecular level also as for the deposition, and clinical level also. How much is the deficiency as far as the IQ is concerned, or the PQ is concerned, the verbal quotient is concerned, and activity of daily living is concerned. Is that patient is bedridden? Is that patient is able to go from one room to the another room? So all these factors is going to make me aware which drug I need to choose, for how much time I have to use. Should I or not add? Should I go for the change of the drug? So this is my experience. This is what I'm telling you. See,
Correct,
it's
sir.
not like that. I will like to be for the A drug, which is very good. I will say these both drug, for me, it's having a synergistic action. I will not
Correct,
say
sir.
that this is better. Why this is having synergistic action? I have told you that this is not only the one component as far as the aging brain, as Alzheimer dementia is concerned. Let's talk of motor activity. They are so slow. They are having as far as their gait is concerned, as far as the turning is concerned, as far as getting up from the commode after attending the nature's call, as far as their verbal capability is concerned, comprehension is concerned, as far as the problem analysis is concerned, neural learning is concerned. That is challenge. So, for example, if the patient is not doing good with the reverse technique, let me talk about the youngster neuroscientists. Okay, fine. They are giving, let's say, most of the time, newer guys, they are not using reverse technique that often in the way I use. Most of the present neurologists, younger neurologists, they go more in favor of donepezil and memantine. I have seen prescription, because there is always cross doctors as far as the patients are concerned. Number of patients coming to me from the various neurologists, they come with donepezil only, even not with memantine. Maybe 5 milligram, 10 milligram, 23 milligram, slowly releasing methodologies. But at the same time, I need to make him more good. So my bet is that It's not like that I will stop donepezil and I will say no, rivastigmine is the more a drug which can address in a better way as far as the removing the donepezil and giving the rivastigmine. I am
Correct, sir.
in the favor of, you can say it, that as far as there are people, I have working at a different level. I have worked at the grassroots level, primary health service level, as far as the public health sector is concerned,
Right, sir.
the government of India in the hill state. I have worked in the best of the best institute for 6 months on the WHO assignment in National Institute of Health. What is more important as far as my patient is concerned, in which way it has to be treated, one may label me anything. See, once something is put from the horse mouth into black and white in a nice methodology as far as the sample collection is concerned, that may be accepted in a better way. But as far as the practice is concerned, more like a clinical neurologist, so I don't have that much time, but to say on my own experience also. On my own experience only, to say that the both combination is having synergistic effect, a good effect, rather than changing the medicine. I usually don't change the medicine. I like to continue that person whosoever is taking donepezil, continue donepezil, add rivastigmine. And I will add even those patients who are in moribund situation are going from bad to worse, even the Ayurvedic medicine. I said it, Brahmi and Sankushvi.
Right, sir. Right, sir. Another, sir, query which actually came was, regarding, side effect with patches.
Mhm.
So more, sir, like you can also share, sir, because you have been using. But here, sir, something which we can also share is the only, something which could be, very rarely seen as a side effect could be, an allergic reaction of the skin. Because a lot of people, sir, have a very sensitive skin, like using, sometimes some different perfumes or hair color, skin might react. So that is the only, sir, side effect which can be developed. Wherein, sir, like to share with you also and the otherwise with the audience, the best way to manage it is for, if there is 1 in 20 patient, which might, if complain, there could be a small a part of a patch could be pasted on a skin for some time for 1 or 2 days. And later, the skin becomes, accommodating towards the patch also. And basically, sir, it's not to the drug, but it is actually towards the glue which is being used. The allergic reaction comes. And just to share, sir, with you, and the audience that, what we have been using, it's a very customized kind of a glue which has been innovated for the use of patients in Southeast Asia, because that's a totally different skin type compared to US and Europe. Right, sir. So that is the only some side effect which would come up. Now, this is a very interesting, sir, question which has come up, which recently, sir, we have been discussing, and a few doctors, sir, particularly in neurosurgery, have been using, and your input would be very, very important on this. Is, sir, like post-traumatic, there are cognitive impairment patients, there are the issues with cognition. So there, sir, doctors have been using, such drugs like rivastigmine. So do you think, sir, it has got some substantial use, or how do you position it, sir? Could it visibly have a role in terms of cognitive impairment for such kind of patients, sir, who have gone to trauma and have some cognitive impairment?
These are the two different things I like to answer. First is the patch. Yeah, I know. Once you told me, I remember two of my patients, they came and they told that they're not sticking properly. There may be problem as far the glue is concerned. So
Okay, sir.
that's
Okay.
just obviously that becomes the rider as far as the viability is concerned, because this is not sticking for 24 hours and there is a problem. Second thing, once you ask me about the trauma and use of rivastigmine, you see, first of all, trauma and decline as far as the higher mental function is concerned, it's a big topic, real big topic. I will tell you, I quote you the statistics. With the trivial trauma, the post-trauma stress syndrome, PTSS, is
ST.
far more common, which need to be addressed with the help of beta blockers or some mild benzodiazepines compared to rivastigmine. You
Okay.
see, there are so many people who will say, no, okay, as far as acetylcholine is concerned, that is good. Or maybe certain other carnitine or some other drugs, which is useful as far as the brain injury is concerned. I will say, I am telling you my own experience with the post-trauma stress syndrome. Post-trauma stress syndrome, there may be very trivial injury. Even the patient has not noticed it.
Correct, sir.
Even that trivial injury can create subdural hematoma. More so in alcoholics. In alcoholics, the likelihood of developing subdural hematoma, even if the small injury, is very high. So we should have a high degree of suspicion. Of course, all those persons who have had brain injury, small or big, must have imaging as far as the CT scan or the MRI is concerned before labeling that this is post-trauma stress syndrome. We must exclude something abnormal or life-threatening situation. So in that, as far as the rivastigmine is concerned, this will be just equivalent to, because I still remember so many things come, citicoline came and people said it, why not? This can be used in this. As and when there is some depression or there is some pseudo dementia, there is a dementia, there is a cognitive decline. I don't think randomly we can use it as the rivastigmine is concerned, and I don't have any experience on this. And per se, I will not like to digest this as far as the rivastigmine role is concerned in brain injury or brain trauma. See, it is open in case you guys you have some reports or some claims. Of course, that is welcome. That can be taken up, and in case it's useful to the patient, that can be thought of.
Right, sir. Right, sir. Right, sir. Another, sir, query which has been there is what could be the, sir, differentiating factor in terms of positioning, sir, both the drugs, donepezil as well as rivastigmine, sir?
Positioning means?
Sir, what kind of patients you might prefer to go with rivastigmine to start with, or the donepezil?
You see, mostly I said it, you see, more the setting, it all depends. Multi-infarct dementia, for example, if there is a patient who had dyslipidemias, who is having cardiac problems, there is a big plaque which is sitting in the carotid arteries, the brain blood flow is less, there is on the MRI or on the CT scan or maybe on the angiography, MR angiography, or maybe digital subsection angiography, there is a problem as the brain cells are concerned. So if there is a multi-infarct dementia, I'll be better with the donepezil rather than this rivastigmine. But at the same time, I said it. See, I want good results. So these patients who come with me, multi-infarct dementia, I just remember, I at the same time must quote you a practical thing. You see, I am talking to the end-stage cardiomyopathy. I was talking to one of the very senior experienced cardiologists, and we were of the opinion end-stage cardiomyopathy, ischemic cardiomyopathy. Ischemic cardiomyopathy means there is the
Yes,
heart has
yes, yes,
started
yes.
dilating and other things.
Correct,
So
sir.
he was of the opinion to give some anticoagulants. So in these patients also, there are so many patients who come to me. You see, basically this is multi-infarct dementia means there is a problem with the blood vessel. Even diabetes in the coming time may be known as vasculopathy rather than diabetes. So in the whenever there is a vasculopathy, this is going to be possibly generalized rather than only localized to only to the coronary arteries, not to the brain arteries. Maybe to the brain arteries also, to the coronary arteries also. So these are the type of patients who come to me with diabetes, maybe the coronary artery problem, and they are already on 1 or 2 antiplatelet drugs. I have to start maybe oral anticoagulants over and above giving donepezil. So in such like situation where there is a multi-infarct dementia, no, it's not a small chapter. That's why I said, no, there is a different things. As there is one type of dementia, what is known as the Winsbinger dementia, and that is seen in hypertensive. That is seen morely because the border zone area, as for the gray and white matter is concerned, over there there is a problem, and they present with a different type of presentation. Subcortical dementia, they are having infarcts are usually more in the white matter. Subcortical dementia, they are having different type of presentation, clinical presentation. So, and of course, clinico-pharmacological, for example, if I go in a patient I cited you as far as the patient is concerned, patient who is showing significant slowing in the EEG, as far as the function of that of the neuron is concerned, vis-a-vis the structure with the MRI or with the PET scan. In case that is normal, So obviously that will go more in favor of multi-infarct dementia plus the MRI rather than primary neuronal dementia. So for such like patients, we like to start donepezil or memantine first. And in case they show improvement or the improvement is not satisfactory, I don't mind adding the rivastigmine to that.
Right. So that's a very precise suggestion which you have shared. Right. So wonderful, wonderful. And I think, sir, these were the, the few queries which have been coming in. Cognitive, sir, you have already addressed, in terms of, its role. So, but definitely, sir, we'll try to get some more, reference papers if they have some role. But you clearly shared, sir, your point of view and your thought on your rivastigmine into cognitive impairments, sir, which are related to traumas. So wonderful. So I think, sir, post the session also there would be some queries which we would be bringing it across. Those
Yeah,
are
sure.
I've been learning personally with you from last more than 2 decades. So you have been sharing your such a enlightened experience with us in terms of your clinical treatments. So with this, sir, I would now take this opportunity on behalf of Hetero and the entire audience to thank you and would like to extend my sincere gratitude for sparing time from your always occupied schedule, sir, which I know has been so busy from last so many years. And to take your time out to speak today and enlighten us today evening on the aging brain and in terms of how we can manage it. Sir, I must say that your presentation was not only informative but also incredibly inspiring and transformative for the audience. The insights you provided has been very resonated with the subject and with the audience. Also, sir, at the same time, another thing I would like to acknowledge, because this is the first any such program we have done with you. Your unique perspective, sir, which I just saw, and your engaging style actually would have brought subject to life. And we are deeply appreciative, sir, not only of the presentation but also for the time and effort you have actually invested in customizing your presentation for the audience and for the related subject. The thoughts, sir, and particularly the experience you shared, I would be more emphasizing on the experience you shared. I think, will be applied in various ways, by the audience and the doctors for managing, patients, particularly with aging brain. And we also spoke about, sir, related dementia onto this. So, sir, please accept this note, as my small token of our gratitude. And so definitely, since I've been meeting you for last so many years, we look forward, sir, at Hetero for many such opportunities and to collaborate again for another program and to have your, sir, expertise and your clinical experience and guidance for other related neurological disorders. And from the core of my heart, sir, I'm really thankful and I feel very privileged to have here and attended your session. And thank you so much, sir, for taking your time late evening and for all your effort you have put in for this presentation. Thank you so very much, sir, for this.
Thank you very much. Thank
Thank
you.
you, sir. Please
Thank you,
take
the
care.
participants. Thank you for listening me, sparing your time. Thank you, you all. You are the part of the treatment. You see, unless because the pharma industry can be seen from the various perspectives.
Correct,
I
sir.
see with a different perspective. I know there are ifs and buts in everything, everywhere, and even a given moment. There is a different sort of opinion as far as I'm concerned. But all said and done, I will say it is a collective work. It's unless you guys are going to come with good alternatives, newer medicines, we are incomplete. Thank you very much.
No,
Thank
sir.
you.
Thank you so much that you have been so generous, sir, appreciating the pharmaceutical industry also. But thank you so much, sir. It's a really pleasure to hear you. And thanks a lot, sir, for sparing your esteemed time from your busy schedule at this point of time of the evening, sir.
My
Thank you
pleasure.
so much, sir.
Thank you.
My all regards to you, sir. Thank you. Thanks, sir. Thanks.